All right. Well, welcome everyone. Thank you so much for joining the May PFCC Partners Community of Practice workshop. Again, I appreciate you all taking the time to join us today. We have some great presenters set up before you in a really interesting presentation. But before we get there, just going to go through some logistics and reintroduce our organization to you all. If you wouldn't mind taking a moment to please introduce yourself in the chat, just who you are, where you're from, and anything interesting that you have going on coming up this summer. I am Lindsay Galley. I'm the Vice President of Programs at PFCC Partners located in Sacramento, California, where it's quite windy and a little chilly today. But I hear it's warming up nicely on the East Coast, so really excited for all of you. Um, let's see. Oh, sorry, flipped ahead. We are recording today's workshop and we'll add it to our PFCC Partners YouTube channel and also share it with everyone who registered for today's session. Live transcript is available. If you go to your Zoom toolbar, there is a CC button and you can access live transcript there. If you have any questions throughout today's presentation, please add them to the chat. We had a few questions come in through registration, so we will spend a little bit of time at the end of today's session going through Q&A and addressing any questions that you all have. So please utilize the chat during the presentation today so we can address those. All right. So really quickly, just wanted to reintroduce PFCC Partners. Our mission is to center the inclusive human experience of health and reinvent through radical collaboration and really be that catalyst for system transformation. Our vision, I think, is a shared one with a lot of our partners, and it's a health system transformed and one that works with people and through communities as a partner in their well-being. We show up every day really living up to these values of equity, inclusion, diversity, and collaboration and solution focus, really acknowledging challenges so we can move forward and resolve them. A little bit more about our organization. So I think we can all agree that healthcare is quite complex. Its systems are difficult to navigate and even more difficult to change. I understand in the southern region of our country right now, a lot of states are experiencing the cicadas, which appear after 17 years. And we relate healthcare improvement and change to that amount of time, 17 years. It takes a long time to make change in healthcare. But what we do at PFCC Partners is we open space within systems for patients and family caregivers to drive improvement, to ensure that changes that are taking place are informed and impacted by the patients and family caregivers that are receiving care and really being impacted by those changes. So we're working with healthcare organizations all across the country to open those spaces for patients and family caregivers to really utilize their lived experiences and drive improvements. So who's going to fill those spaces? Well, we have a network of people with lived experience, the PFA network, who we partner with to fill those spaces with their own impactful people, stories, and insights. I'll put a link in the chat so you can learn more about our organization and the PFA network. And please let us know if you have any questions. All right. So I am thrilled to have both Shannon and Anna with us today. They will be addressing the top 10 patient safety concerns through patient-family engagement, something that we are always promoting, utilizing patient-family engagement as a strategy to address safety and quality improvement and patient experience and so much more in healthcare. So very excited to have you both with us today, and I will pass it to both Shannon and Anna to introduce themselves and get us started.
Thank you, Lindsay. And Well, Anna is bringing up the slides. I'll just introduce myself, and then I will let Anna introduce herself when I hand it over to her in just a minute. But my name's Shannon Davila, and I'm the Executive Director of Total System Safety at ECRI. And my background is I'm a nurse, an ICU nurse with experience in quality, patient safety, and infection prevention. And I've been at ECRI for 4 years now, and I lead the work of our patient safety organization, as well as our evidence-based practice center and some other areas. So Anna, how are we doing? Are we?
We're doing okay. I just had to get some permission to share, which I was just given. So
okay.
Thank you so much. And I will be bringing up. So hoping I could get this, up by the time you were done with your introduction. Okay. Can you confirm that?
I can see it now. Yes.
Excellent. Thank you.
Thanks, Anna. So we are excited to be here today. And just as you see, again, we are from ECRI and the Institute for Safe Medication Practices, or ISMP, as some of you may know it, known as the PSO. And we are happy to be celebrating our 15th anniversary this year as a PSO. So let's go to the next slide. So over the next 54 minutes, we're going to give you a nice overview of how our PSO uses a learning system approach to identify and then share the list of the top 10 patient safety concerns. This is our 14th year doing this. So every year the list is different, and we're going to talk a little bit about how we identify the concerns. We're also going to talk about the impact of some of the concerns on the list. And then we will talk also about how you can use a total system safety approach to think about which recommendations may be best to implement within your care settings, and especially through that lens of patient and family engagement. So we'll go to the next slide. Just a disclaimer here, and we can go to the next slide. So as I said, that's me, and I'll let Anna introduce herself when she gets to that. Oh, you can go back one, Anna.
Oops, there we go.
So I just want to let people know, some of you may have heard of ECRI before. Some of you may have heard of us and been like, I don't know what they do. And we just launched our brand new website this week, and our old website did not really help to explain who we are, although our new website is much better. So I just want to give you a quick little history lesson. So this is Dr. Joel Noble, who you see in this photo here. He founded ECRI in 1968. So we have been around for a long time, like 56 years. And we are a nonprofit or patient safety organization headquartered in Pennsylvania. And Dr. Noble, it's a kind of an interesting story. He was a physician, and he was caring for a patient in a local Philadelphia area hospital one day, a pediatric patient who went into cardiac arrest. And when he went to try to resuscitate the patient, both of the defibrillators that he was able to get access to in that facility did not work. So the patient died. And at that point in time, he decided to dedicate his life and his career to patient safety. And he started ECRI at that point. And back then, when he first named it, it was called the Emergency Care Research Institute. So that's where the ECRI came from. And over years, our name has evolved from, that to ECRI, ECRI Institute, ECRI Institute, and now we're just known as ECRI. And I just want to point out that that desk-looking thing that he is leaning on right there, that is actually one of the first renditions of a code cart, what we now know as a code cart, which is, of course, when a patient goes into cardiac arrest, that's what the nurses and the doctors all rush to the bedside. And he named it the Max cart. And it was one of the first versions of that. And there's only 2 of those left today. One of them is in our headquarters in Philadelphia or in Pennsylvania, and the other one is in the Smithsonian Institute in Washington, D.C. So just a little fun fact for you there. All right, so let's go to the next slide. And in those 56 years, ECRI has grown. We are, as I mentioned, a patient safety organization, which means we are certified by AHRQ, the Agency for Healthcare Research and Quality. We're also an evidence-based practice center certified by the Agency for Healthcare Research and Quality. We are the only dually certified organization in the country to be both an evidence-based practice center and a PSO. And we also do what Dr. Noble, his original founding was around device safety. We continue to do that, and we are the only independent medical device lab in North America. We're only about 500 people. We do a lot for a smaller organization. So let's go to the next slide. As a PSO, and I will tell you, this really informs our top 10 list, is that we work with our patient, healthcare providers from around the country, and they send us their safety data. we have over 7 million harm events in our database. And I don't say that number with glee. It's a big number. I say it with a lot of heavy responsibility, because that's 7 million moms and dads and neighbors and brothers and sisters, colleagues that have either been harmed in healthcare or nearly harmed. And so we have this database. And as part of that responsibility is that we go through that information all the time, and we're able to understand what are the biggest risks, what are the biggest threats to patients and team members that work in healthcare. And that really helps to inform our safety, the list that we're going to talk about today. So let's go to the next slide. And we use that data. We do a lot of analysis on it. We share it, but we consider ourselves a learning system. At the end of the day, we want people, healthcare providers, patient family advisors, patients, to learn from our PSO. We want to share the things that we identify. That's what we're here for, is to share information and have others learn so they can implement better practices at the bedside. Let's go to the next slide. Okay, so let me get to the top 10 list then. So how do we get the list, right? That's what a lot of people ask us. And so, we have a lot of safety and quality experts and risk experts at ECRI, but we also have human factors engineers, we have biomedical engineers, we have lots of different folks, and we're able to get access to lots of different data. And so we look through our data, we do a lot of analysis, we look for trends. We also use our colleagues at ISMP, we look at their database and accident investigations, all these different things. And we're able to identify those priority issues that healthcare providers have seen over the past year. And so if we go to the next slide, did Dr. Noble help in the design of the original code card? Yes, he designed the original one. Yes, he did. That was his invention, actually. So, sorry. So selection criteria. So can you imagine with an organization like ours with 7 million events, how do we then narrow it down and decide which concerns are the ones that want to make our list? So we do have criteria that we use, and we have our team of experts that review we review all the events that we look at, and we make the determination. So we look at the severity. How serious would the harm to a patient be if this safety concern were to happen? The frequency. So how likely is this event going to occur? The breadth, which is, if it were to occur, how many patients or team members could it possibly affect? The insidiousness. So is this a problem that's difficult to recognize or challenging if you found out about it? And then the profile. Is it something that is going to get a lot of attention? Is it going to bring a lot of scrutiny to a healthcare organization? So we look at all of these criteria as we're going through our potential concerns, each list, and that's what helps us really narrow it down to the top 10 things. Now, I will say that when you look at our list, which I'm going to show you in just a minute, not everything is new. In fact, a lot of the issues have been on the list for some time, but generally there may be a new study that came out, or there's new perspective from patients and families on a topic, or there's new guidelines, and that really kind of helps shed light on the issue again, and it brings it to the forefront. So if we go to the next slide. Now, not only do we identify the concerns, but we also talk about what are best practices to help prevent them from happening again. And so you see this image on the left-hand side, which says total system safety, and it has these 4 foundational areas. So we have leadership, culture, leadership, and governance, which is about how leaders can be involved to improve safety. Patient and family engagement, of course, and we're going to talk about a lot about that today. Workforce safety and wellness. So how can we support healthcare workers and providers to provide that care in a safe environment, not just physically safe, but also psychologically safe for them. And then finally, the learning system. How can healthcare organizations use this data to really learn from it and then spread best practices? Now, I will say that these 4 foundations come from the National Action Plan to Advance Patient Safety, which is a plan that comes from the National Steering Committee for Patient Safety. ECRI sits on that committee. We are one of 27 organizations in the country that sits on that committee. And in 2020, we released the National Action Plan for Patient Safety. So these 4 foundations are from that plan. So if we go to the next slide. Okay, now what everybody's here for, the list. So I'm just going to share this list. I'm not going to read all these things because Anna and I are going to go through these one by one. But again, some of these are really hot topics. technology adoption. Of course, everybody's talking about AI right now, so that's a really hot topic. But some of these, like number 10, patient falls, that is not a new topic. But because we continue to see that as one of the number one sources of harm, the Joint Commission just released their Sentinel event report recently, and it says it's still one of the number one Sentinel events. So, that brings it to the list again, because we know that we have to do better. So I'm going to go ahead and turn it over to Anna to take you through items 1 through 5.
Okay, thank you so much, everybody. And my name is Anna Thomas. I'm a patient safety analyst with ECRI and the ISMP PSO. I'm a critical care nurse by background and also a clinical nurse leader. And I'm also a rare disease parent. So patient and family engagement is, I would say that's a personal and professional passion of mine. And I really appreciate the time to give this talk with you guys today. So our number one of our top 10 patient concern is challenges transitioning newly trained clinicians from education into practice. And of course, this really stems obviously, from issues around the pandemic, but even before the pandemic. So we know that, the typical volume of the clinician's hands-on and in-person educational experience was disrupted by the pandemic. This was added to a growing workforce shortage, demands, and this really can result in an increased risk of harm to patients as these new clinicians transition from education into clinical practice. Looking at the data, we see that without sufficient preparation, support, and training through that transition to practice, new clinicians can experience loss of confidence, burnout, reduced mindfulness around cultural safety. And all these factors can really come together, to maybe lead to a failure to recognize or rescue patients from preventable harm, or even just contribute directly to patient harm events. So some of the issues that we see are a shortage of trainers and training programs. So according to AACN, which is the American Academy of Nursing, there's an insufficient number of faculty, clinical sites, classroom space, and clinical preceptors that resulting in nursing schools that actually are turning away tens of thousands of qualified applicants. And that's hard for me to believe, because I remember when I was in nursing school, I think it was 700 applicants every semester, and 35 would get chosen. So just to know that that's how it was years ago, and that now they're even turning away more than that is it's really hard to believe. We also have an issue around expertise understaffing or an experiential knowledgeable draining. So knowing that upwards of 800,000 registered nurses are likely to leave nursing by 2027, and also 124,000 physicians is also predicted to leave the workforce by 2034. This makes it more difficult for new clinicians to work alongside those seasoned professionals. I mean, I know when I was a nurse, that was the first person that I would seek out would be, some of the nurse that's been at this for 10 or 15 years, and I knew I could go to them for that support. Unfortunately, that's really hard to find anymore. And it also, leads to increasing new clinicians' workloads at the same time. And then again, burnout. So there was a study that showed 42.5% of new graduate nurses reported they were considering leaving the field of nursing. This is a really unsettling sign that the burnout's really affecting new staff and not just senior clinicians. There's also some data showing that the physician burnout rate is over 60%, and factors including work overload, sleep impairment, those all contribute to burnout, but also specifically from medical residents and medical resident burnout. So, as you're thinking about this and thinking about new clinicians, I would encourage you to think about what do we want new clinicians to know around patient and family engagement, and how can we get them more involved? How can we get that included in training programs? And I think back again to my time as a critical care nurse, and I did work through the first wave of the pandemic, and I worked with many newly trained clinicians, nurses and respiratory therapists and medical surgical residents. And I really thought they were the bravest people I've ever met, right? Because they really just came in with limited knowledge and kind of had to jump right in. So we just have to really consider, some actions around how we can strengthen efforts to support those new clinicians as they enter practice. And we can make some recommendations using that 4 foundational areas of total system safety that Shannon had mentioned to inform these efforts. And you'll see as we go through each of these topics that we're going to be using those 4 foundational areas as, a way to inform recommendations. So thinking from that culture, leadership, and governance perspective, it could be around creating collaborative partnerships among academic and healthcare institutions, and really supporting development of robust transition to practice programs. So that might look like nurse residencies, other ways of orientation and immersion programs, around patient and family engagement. We want to help new clinicians develop strong patient engagement skills. So considering tools such as ARC 60 seconds to improve diagnostic safety. That is a tool that allows the patient to tell their health story without interruption for 1 minute, which doesn't seem like a lot, but I encourage everybody to think about a time they ever had the opportunity to just speak freely for a minute, maybe at an appointment without being interrupted. And that also allows the clinician to ask questions to deepen understanding. And then seeking input from patient and family advisory councils on how newly trained clinicians can improve patient-centered care. And then a quick look at workforce safety and wellness, thinking about adopting wellness programs that help new clinicians to develop resiliency and find meaning in their work, and building a culture of safety that empowers those new clinicians to report safety events that impact themselves, their coworkers, and patients. Thinking about those events that might highlight unsafe working conditions, performing tasks outside of their competency, or the need for additional training. And then lastly, using that learning system. So again, including patient safety training is that as a core element of education for all new health professionals during their academic time and also when they're in the healthcare workforce. Our next concern, number 2, is workarounds with barcode medication administration systems. And this is one that, has been around for a while as well. So if anybody is not familiar with this, barcode medication administration or BCMA, these are when the nurse comes in to give medications, they might scan that medication before giving it. These are really important tools for preventing medication errors. But, with any technology, there always can be issues. So scanning or labeling errors can lead staff to develop workarounds. Those workarounds can compromise patient safety and have really unfortunate consequences. So some reasons that staff may employ a workaround might be that a barcode can't be scanned. It might be difficult to scan. Sometimes the barcode be missing, hidden, or damaged, or if a medication hasn't been added to the system yet. And again, you'll see some examples of unsafe BCMA practices, which we talked about a little bit already, but that would be giving that medication even though you're not scanning it, or scanning and charting after a medication's already been given, not understanding why an alert is firing, or scanning a different barcode rather than the one that's attached to that medication. And on the right of this slide, this is an interesting sort of deep dive into a very large number of medication safety issues that were reported to ECRI and the ISMPPSO back in 2019. And we found that 66% of those were related to barcode scanning issues. So it's actually the most frequently reported technology issue. And it's interesting, as a parent, I've had experiences where I can think of one especially where I was in the hospital with my daughter, and the nurse came in just with a big cup of pills to administer for her evening medications. And I have to tell you that I'm a nurse. I work in patient safety. I'm very well, I versed in all of this, and I had the hardest time stopping her and speaking up and asking her, what was she doing and had she scanned those medications, and to really tell her that I wanted her to dispose of those and start over with medications that I could see that had been scanned at the bedside. So I think that if it was a challenge for me to do that and to bring that up and have that conversation, I can imagine, what that is like, for everybody. So something to think about from that patient and family perspective is how can we help patients and families, members feel comfortable about speaking up if they see something like a workaround occurring, and how do we let them know that they should expect medication to be scanned at the bedside if that's available. So again, we look at these recommendations through that total systems perspective, around culture, leadership, and governance. So this is convening, teams that review practices that may lead to barcode workarounds, developing modifications and configurations that address system issues and support for safe clinical workflow, and developing an escalation process for what to do if a barcode won't scan. So what should that nurse do if they have a medication and the barcode won't scan? How do you report it? Do they understand why is it dangerous to use that proxy, and who's responsible for monitoring? And again, looking at it through that patient and family engagement perspective, it's education, right? We have to explain to the patients and families that practitioners are expected to scan each medication prior to administration, and encourage them to speak up if that task is not completed. And if there is an adverse event that occurs as a result of a workaround, this needs to be communicated to the families. Around workforce safety and wellness, we want to think about utilizing clinically informed human factors engineering methods to assess challenges with the integration of technology into clinical workflows, and think about a reporting and recognition process to acknowledge staff members that do speak up and report near-miss events related to barcode scanning. And then around the learning system, we have to think about our goals, right? Setting improvement goals that align with benchmarks, safety standards, reporting those serious safety events that involve barcode medication administration, assess for contributing factors related to workarounds or equipment malfunctions. And if there are, specific barcode scanning issues that relate to a product, there's places to report that as well. Okay. Here's another really big topic, barriers to access maternal and perinatal care. So it's really challenging to believe that we're here in 2024, and the United States has a maternal mortality rate that's currently ranked as some of the worst among affluent countries. We know that about 1,200 patients die annually, and another 50,000 suffer pregnancy-related complications or severe morbidity. And we know, why some of this harm is caused. So a lot of it is around limited access to care, which increases the risk of pregnancy-related deaths, infant mortality, any other adverse outcomes that are associated with unintended pregnancies. And one thing that I think is really important to note is that people of color and other vulnerable populations are disproportionately harmed by these barriers. Another issue that we see is around maternity care deserts. So we see that there's 2.2 million women of reproductive age that are living in a maternity care desert in the US. There's over 1,100 counties that have no hospitals that provide obstetric care, no birth center, no OB/GYN providers, and no nurse midwives. And that's really hard to believe. And it's actually projected that by 2050, we talked about the physician shortage, but there's going to be a deficit of 22,000 obstetricians. Some of the issues around, why is that a problem? There's reimbursement issues. So reimbursement for obstetric services, especially covering a full year of care after birth, is not consistent across the country. And these are barriers that, are really contributing to preventable maternal fetal harm and increasing U.S. maternal mortality rate. And of course, then there's the issue with the Roe v. Wade reversal. So with that, providers are facing legal and ethical challenges. They receive, conflicting guidance on how to manage high-risk patients. And it does unfortunately have an impact on future access to maternal perinatal care, not only around the provider's decision of how or when to provide care, but also, their decision to continue in practice or even choose a career in obstetrics. And this just shows distribution of obstetric providers by county. And again, this is from 2019, but it does, give you an idea of these maternal deserts, as it were, and all of these, orange or darker orange, those are the areas where there could be 0 providers. So think about it from that perspective of patient and family advocates, and how can we influence this? Is it through lobbying? How do we ensure that advocates know what available resources are, or what resources are available to maybe share with people seeking care? How are we able to support patients and families without any fear? So thinking of it through that culture of leadership and governance, we have to really prioritize preventable maternal harm as a quality improvement goal and align it with United States maternal health initiatives. We need to advocate for public policies that extend insurance coverage to 12-month postpartum, promote family planning services, thinking about how to reimburse community partnerships with midwives and doula care, home visiting programs, and then develop obstetric workforces that support care in those maternity care deserts. Around patient and family engagement, this is a lot around empowerment and education, right? We need to empower patients to speak up, to raise concerns. If they suspect warning signs of a serious pregnancy-related complications, they're likely to have to do, a little bit more self-advocacy now. Employing health literacy, encourage culturally and linguistically appropriate care. For workforce safety and wellness, we like to talk about great catch reporting programs. So we talk a lot about harm reporting and patient safety events, but we also like to see when things go well and maybe harm was prevented. So we talk about great catch reporting programs that would identify potential harm and prevent harm from occurring, developing plans to provide both physical and psychological safety for staff when they're providing perinatal care during stressful or traumatic instances. And again, using that learning system. So that's your event reporting, also simulation, scenarios, feedback, training is going to be really important for this. All right. Unintended consequences of technology adoption. So one of the questions that we saw submitted to us before our talk today was around the EHR, and is the EHR really making us safer? So we're going to talk a little bit about that through looking at technology adoption. So this is a hot topic, right? Everybody knows about AI. We're looking at this as a new wave of emerging technologies. So AI, machine learning, digitally mediated diagnostics and treatments. We see that AI has been successfully used in healthcare for applications such as medical imaging. However, its quality really depends on the data used to train the clinical AI application. And it's important to note that unreliable AI functionality can actually result in misdiagnoses or inappropriate care decisions. There's also other challenges, with AI that are seen on this slide. So for an example, one of the challenges we face is bias within AI data and thinking about how that can affect accuracy and effectiveness. We know that AI applications are inherently biased towards patient populations that resemble the population used in training the algorithm, which may not be representative of all patient populations or the current patient that's utilizing this. So I'd like to offer a scenario of to help with understanding. So think of a hospital implementing an AI-powered triage system to prioritize patients in the ER. This algorithm might be designed to analyze patient data such as symptoms, vitals, medical history, et cetera, and predict their risk of serious illness. This sounds great, right? I mean, this sounds like a really helpful tool. But if the training data for the AI system primarily comes from patients who are white, who have commercial insurance, other circumstances, this means that the system is going to be less familiar with the health patterns of minority patients or of those on public insurance. So we think that the AI system can actually under triage minority patients, those on public insurance, and that could lead to them waiting longer for care or missed or delayed diagnosis, and obviously potentially then a worse health outcome. So the takeaway here is that we have to validate the algorithms that are used in these applications. And this slide just shows how AI is present and in use across the healthcare system. So these are technologies that they are becoming routinely used in healthcare with many positive outcomes. I mean, I think everybody, their use is also present, they present concerns that safety issues can arise. So again, looking at it through our four domains here, culture, leadership, and governance, we have to think about committees, establishing multidisciplinary committees to really evaluate new technologies and determine risks, including representatives from leadership, clinical services, human factors, engineering, clinical engineering, patient safety, risk management, patient and family advocates. Everybody needs to be on these teams that are looking at this technology before adopting it. Thinking about establishing policies on the implementation of technology that incorporates AI, including pre-deployment and ongoing validation and testing protocols. And then again, patient and family engagement. So we need to be prepared to address questions, right? If patients and families know that they're coming in and that this technology may be a part of their care, we need to be able to address those risks and answer any questions. Consider engaging patient and family advisory councils in order to understand what is the patient's perspective on the impact here. How do they see it impacting their health or their health literacy or shared decision making? For workforce safety, again, thinking about staffing shortages, burnout, cognitive overload, all the things that we've been talking about. But how could that potentially contribute to over reliance on AI or misuse of AI or other emerging technologies? And again, always using those clinically informed human factors engineering professionals to help perform assessment of clinical workflows and how they may impact or how they may be impacted by new technologies. And then, of course, we have to train staff and emphasize the importance of reporting unusual results, and also tell them that, a clinical judgment is still a valuable part of this picture here. Right. So the fifth concern is a decline in physical and emotional well-being of healthcare workers. And I think we've talked a lot about this over, you can kind of see from the first four topics, like what could lead to this. And we know that healthcare workers have long been subjected to stressful work environments that affect their emotional and physical well-being, but ongoing challenges that, during the pandemic and post-pandemic, they've really exacerbated the problem. So just going to give you some statistics. So as of October 2023, U.S. healthcare employment across the continuum remained over 480,000 jobs below projected levels based on pre-pandemic trends. In 2022, nearly half of U.S. healthcare workers reported feeling burnout. They also experienced anxiety symptoms, depression symptoms. And one study found that 67% of medical staff fulfilled the criteria for burnout 2 years after the pandemic outbreak. So I'm not sure that we really, solved some of the problems that they were facing at that time. And it sounds like there's really some ongoing struggles. Another issue is around workplace violence. So a 2023 survey found that 40% of U.S. healthcare workers experienced an incident of workplace violence in the last 2 years. And, the industry is also still recovering from pandemic-related supply chain vulnerabilities. So a lot that really can contribute to this decline of physical, emotional well-being. So rampant physical and emotional exhaustion from stressors such as those listed on this slide, they really contributed to many healthcare workers leaving or contemplating leaving the profession. And again, this creates this cyclical effect of increasing stress for the remaining staff, potentially compromising patient safety. We talked about how it contributes to issues with new staff, with not having, those more seasoned staff members to rely on. And it is an unfortunate sort of vicious cycle. So something to think about, as we're talking about this well-being of healthcare workers, and how do we get patient and families engaged in this? Where can they help address some of these issues? Is it really looking at workplace violence and maybe helping to understand how we can partner with patients and families to prevent workplace violence. That might be one area that we could really dive into. But looking at that culture, leadership, and governance, we have to be thoughtful about always creating a culture of physical and psychological safety, eliminating stigma around behavioral health needs, setting up that tone of connection. And the support has to come from the highest, from the highest levels, from the board, the executive and senior leadership. They really need to prioritize workforce well-being. And then increasing awareness of well-being resources such as EAP, peer support, other programs. Again, patient and family engagement. So we talked about, how can we leverage patient and family engagement committees? How do we communicate patient and visitor codes of conduct for safe and healthy patient-provider relationships? I know I've seen a lot lately walking into different healthcare institutions, and we sort of will see signage around behavioral expectations. Is that effective? Is that enough? It's something to discuss. And then for workforce safety and wellness, behavioral emergency or crisis response teams are really important, along with peer support and psychological first aid. And then we need to use our data, right? We've said this really for every topic. You have to use our data to identify those issues, and that what are the issues, and how can we create effective solutions? What are the existing physical and behavioral health resources? And again, including that staff perspective is really important. So with that, I'm going to turn it back over to Shannon.
Right. Thank you, Anna. And so we're going to move to the second part of the list now. And the number 6 is the complexity of preventing diagnostic error. And I will tell you that if you have experienced getting your health care in an ambulatory care setting, which I'm pretty sure that 100% of us have, then you may have experienced a diagnostic error. Ambulatory care, 50% of all diagnostic errors occur in ambulatory care. And if you're a woman or a minority, you have a higher rate of experiencing a diagnostic error. And diagnostic errors can be minor, from maybe having a minor delay that didn't really cause anything, or it could be major, maybe missing a test that shows you have breast cancer. Okay, so it can be range all over the place. And the diagnosis that we see that have the biggest opportunities around diagnosis is stroke, sepsis, pneumonia, venous thromboembolism, which is a blood clot, and lung cancer. So these are the areas that we see the most opportunity to prevent these. And as you see over on the right-hand side, there's many, many different risks. So we're not going to go into all of these today. But when you think about that diagnostic inequality, many different things can impact that. So this is a really big, serious deal. So let's go to the next slide. Now, it's complex, right? And that's why this issue is complexity of preventing diagnostic error. If it was a situation where we could just, put a new policy in place, or, push a button and everyone gets notified of the results, we wish it was that easy. But there's many different things. And you see here that it ranges from communication failures to different kind of cognitive bias that healthcare providers have, which may lead them to miss a diagnosis because they're thinking about something else. There's, patient information not being complete. Everybody's rushing now, right? So there's limited time with patients. So you may not get that accurate, as a patient, you may not be able to give that accurate information to your provider so they can make a really good, solid diagnosis. And then lots of different patient factors, including language, literacy, and different things like that. And you see here that 40% of patient encounters, well, this is what I said. I think 50, that's the stat that I saw, 50 involve medical tests in primary care. And so certainly a big opportunity. So let's talk about what we can do to prevent diagnostic error. Well, what can leaders do? Well, first, they can actually message and communicate that this is a priority for their organization, right? We all look to leaders within health. They set the culture within their institutions, they set the priorities. And so they need to be able to assess what the risk is and then set that as a priority. Once they understand what the data shows, what their diagnostic outcomes are, then they need to really develop that infrastructure around how they're going to improve. And that includes developing the infrastructure between across care settings, and so that you're able to transmit results and data much faster, and so that it can get to the right hands of the right people that can make the right decisions. For workforce safety and wellness, a big part of diagnostic error is around cognitive bias. And so cognitive bias, it's different than, implicit bias. Cognitive bias is when you are sort of, you're not thinking about what the potential diagnosis is because for some reason, you're convinced it's something else, for example. And so part of cognitive bias training is just to get providers to understand that there may be other ways to think about it, and getting them to, understand that doesn't make you a bad doctor or a bad nurse, but we just need to expand the way we think about diagnosis. And also provide peer support to staff members after a diagnostic error event. Anna's already talked about peer support and the importance of taking care of our team members. I mean, you can imagine how a team member or a nurse or a doctor would feel after missing a diagnosis for a patient. And it's devastating. And so we want to make sure that we're supporting our team members to know that we're going to support them. We're going to fix the system around them so that that doesn't happen again. And learning system, using evidence-based tools to measure their data and to really figure out, what their diagnostic error rates look like in their institutions. And then for patient and family engagement, patients have a big role in this. Part of it is around communication and being empowered to be able to speak up and ask for information. If you're not getting your results in the time that you were told to, close that loop, reach out. Where's my results? What's going on? Healthcare providers need to develop shared decision-making tools. And so this is really creating that co-production of care between the provider and the patient and saying, what are our goals together? What are we going to, what's the plan when this diagnostic test comes back? What is the expectation if the result is not back in a certain amount of time? What should the next steps be? So patients and families do have an important role. It's really around being engaged, being informed, and then really being communicative with your providers. Let's go to number 7. Number 7 is providing equitable care for people with physical and intellectual disabilities. So over 27% of all US adults have a disability, and 41% of physicians feel very confident in providing that care. Well, what that means is that 59% of physicians don't feel confident. So, and we know from the data that people with disabilities can have much higher rates of adverse health conditions, mental health issues, and maybe, also be at a higher risk of being involved in abuse and violence and neglect. So let's go to the next slide. So this graph shows us that the percentage of US adults with disabilities reporting selected health conditions compared to people without them. So what we just said, and you see that the blue bars represent people who have a disability, and then the yellows are people without. And you can see that for obesity, heart disease, diabetes, sexual assault, mental health, that you are at higher risk if you have a disability of some of these common and unfortunately these are obviously chronic and acute conditions that patients can be higher risk of. And, again, lots of different factors, and they include, not having a healthcare provider that can adequately manage your care, perhaps not having consistent healthcare or routine checkups, and then diagnostic overshadowing, which means when a provider makes an assumption that if you have a disability and you have behavior related to that, then that behavior can't be related to anything else. It has to be related to your disability. So we were just talking a moment ago about cognitive bias in diagnostic safeties. This is another risk around that. If you have a disability, then part of cognitive bias could be that your provider is not attributing some symptoms or signs that you might have for something that's related to an acute condition. They may be attributing that to your disability when that is not the case. So let's go to the next slide. So some things that we would recommend. Leaders obviously want to do an assessment of their organization and make sure that everyone is getting that full and equitable access to services, including patients with disabilities. There's a lot of requirements out there for how we deliver care, how we communicate, how we can provide support to people that need different accommodations. And you need to ensure that you're in compliance with all those requirements. And in creating this as an organizational goal to promote disability competent healthcare values. So when leaders start to integrate this into the goals, then it feeds down to the rest of the organization. People realize that this is a priority. Now, what can staff do? We can make sure that the staff communicate the presence of service animals at every handoff, right? We know we have a lot of patients that come into the outpatient or inpatient settings now and have support animals for lots of different things. We've seen them for patients that are diabetic, patients that have seizure disorders, anxiety and depression. And it's important that we respect those patients, that we treat those animals like they are part of their care, and that we're able to really support that. And then if there's any special equipment that our patients need, we need to make sure that our staff are competent in how to use that equipment safely and effectively. That's really important. Now, from a learning system perspective, again, we always go back to data, and healthcare organizations should be analyzing their safety events that are related to patients with intellectual, and physical disabilities. And then again, providing that that training on both cognitive and unconscious bias to healthcare providers. Now, what can patients and families do? Well, you can assess, and we ask healthcare providers to assess and document the patient's health literacy and capacity to provide informed consent. That's a big one. And so safety leaders and risk managers need to be working together in those environments in which patients may be giving informed consent, and really making sure that the patients, they have the right tools to be able to get that consent in a safe way. Discuss any necessary accommodations, what I just spoke about, with the patient prior to their visit. So this is an important part of pre-planning, particularly in an outpatient environment, and so that you can be prepared to adequately, have that patient have a safe encounter with their provider, and that you're able to really be able to treat them in an effective way. And then including an individual with a disability on your patient and family advisory council, right? This is just bringing that perspective to that organizational team, which is really important. So let's go. I'm just keeping one eye on the clock. Let's go to the next issue. Number 8 is delay in care resulting from drug supply and equipment shortages. And I will say that we've seen since, well, even before the pandemic, but certainly after, we've seen equipment shortages, related to both natural and man-made issues. And this is a big deal for healthcare institutions. And sometimes these can be products or supplies, but they can also be medications. Let's go to the next slide. So a few things here. Organizations need to make sure that they are taking inventory of their critical supplies. That is really important. And they need to work with the manufacturers to ask for transparency so that they can be better prepared if there is a supply disruption. Workforce, there's a process called tiered safety huddles, which is a way that most healthcare organizations are able to escalate really important information quickly across the organization. Generally, they do a huddle in the morning at the unit level, and then maybe the manager level, then the leadership level. And if there are any important supply shortages or drug shortages, they're able to escalate that information so that everybody knows about it really quickly, and people can make, they can pivot quickly so they can ensure that there aren't any disruptions in patient care. Again, learning system, we want to look at our data and find out where are our risks. And then for patients and families, that communication piece is really important again. And I think this is a huge opportunity for organizations to be able to better communicate, particularly around drug shortages to patients, and then what the expectation is if there is a drug shortage. I mean, I've had my own personal experiences where I was going to get a refill at my pharmacy, and for a medication that if I don't have it, bad things happen. And they told me, oh, there's actually a shortage and it's going to be a month. And I said, that's unacceptable. Why am I just finding out about this 3 days before my prescription is due to be refilled? So that communication piece is very important. Let's go to number 9. Number 9, misuse of parenteral syringes to administer oral liquid medications. This is something that a lot of you may not be familiar with, but this is a big deal for clinicians. So I'm just going to point you out to the picture that you see here. Now, syringes labeled 1 and 2, these have the end of the syringe where it actually connects with the tubing that is on the patient. That is a special connector, and it's only designed to connect to a tube in which you can put medication that is intended to go down through your oral tract. Now, these other syringes, they can connect to an IV tubing that goes into your arm. It can connect into a tube that goes into your mouth or a tube that goes into your stomach. The risk here is that healthcare organizations have these syringes that clinicians, they don't really recognize which tubing they're supposed to connect to. So the risk is that you could give a medication that's supposed to go in your mouth into your arm, and it can go into your cardiovascular system and cause really severe harm. So if we go to the next slide, this is really about supply and organizations being aware of these types of syringes and purchasing the right kind. And there is a special kind out there that we recommend. It's called InFit devices. These are what are recommended for when you're giving oral medications. And I'm going to skip right to the patient and family engagement piece on this. If patients and families that are caring for loved ones, that they're going to have to be, you know, at home care, and they're needing to be, you know, giving this medication orally, they should really know that there's a special kind of syringe that they should use here. So my advice is, if you ever work with home care patients that and there's an opportunity that they're going to need some kind of oral medication, you should ask for the right syringe. We just need to make ourselves more aware of this situation. And the last issue on our list is, again, this is the issue that's been around forever. And unfortunately, we continue to see falls as a really big safety issue, both in acute care, in home care, in nursing homes. It's across the settings, and it's not just elderly patients, it's young patients as well. And it's a big issue, and unfortunately, severe harm can incur when a patient falls. So some of the recommendations we have around falls, it's really, you know, there's a lot of that organizations are doing. There's fall alarms, there's virtual sitters, but you really need to take a holistic approach to understanding why falls are happening in your organization. If you just try to band-aid these problems, they're going to continue to happen. It takes you know, organizations should have a fall prevention team. They should definitely work with patients and families, either through their PFAC or through bedside rounding, but to find out where do you see the risks of your loved one falling? What are you seeing that we may not see? That information is really important to healthcare providers, and so that they can redesign the setting, because any of us could be a victim of a fall, right? It's just one of those things. You get in the hospital, you're in an environment where you can, you know, get medications you're not familiar with. You may be unsteady because of, you know, the condition you're being treated for, and it just poses a really severe risk. So that is our list. If we go to the next slide, and the next one, this is how you all can download this report. So if you scan your phone on this QR code right now, you can actually, it'll bring you to the ECRI website.
Where's my phone?
Well, and actually, as I'm speaking, I'm hoping it brings you to the right website, because we just launched our brand new website
Just thinking
yesterday.
about that.
I don't know if it will actually, but we can share the report. If it doesn't work, I'm actually going to test it out on my phone right now. If it doesn't, oh, it does work. Okay, good. We're safe. So you can download the report there. And I know we have like just a minute left for questions.
Yeah, thank you so much, both Shannon and Anna. This was just chock full of amazing information, and we'll definitely follow up with the link to the report. And if you can post the link in the chat, I was trying to grab it really quick, but it was taking me a minute. We will be emailing it out in follow up. I think in the last minute, there was one question about sustaining, you know, safety programs and protocols, and just wondered if you had any insight into the sustainment of, you know, some of these improvements that you've offered today.
Oh, I'm sorry. I'm getting the report link here.
Oh.
I mean, I think sustaining, it takes, you have to establish measures so that you're measuring it. right? As soon as people take their eye off the ball and they stop measuring something, then it doesn't become a priority anymore. So organizations need to measure, you know, their outcomes. They need to measure process related to all these, because, you know, people, other priorities come along. That is really one of the keys to sustainment, is to be data driven and to have leadership engagement. You have to have your leaders that stand behind this as well. I think, I mean, Anna, what else? Do you have anything else to suggest?
Well, I'm going to take it a step back and say that to get to the right sort of measures to even be sustainable, we have to look at it from that systems perspective. So that's what we really tried to do, you know, with this presentation and with all the work that we do around total system safety. If you don't understand the problem from that systems level, that systems perspective, and how all the systems are influencing this problem, you won't likely get to something that is a successful and sustainable measure. So that's my spiel, is, you know, we can't do anything if we don't think about how patients and families are involved. We can't do anything if we don't think about workforce wellness. We can't do, you know, we can't do anything without looking at it with through all of those lenses.
Absolutely. Yeah, that holistic kind of picture of our healthcare environment. That's great. Well, thank you both so much, Shannon and Anna. This was extremely informative. I appreciate you taking the time to share with us today. And thank you to everyone who participated in today's workshop. Again, we'll follow up with this recording, and we'll reshare the link to the report as well. So thank you all, everyone. I hope you enjoy your a great holiday weekend, and we will see you at next month's Community of Practice workshop. Thank you so much,
everybody.
Thanks,
Great.
everybody.
Take care. Appreciate it.